I think you all know from the dermatology, 5 questions at least expected, 5 to 6. Sometimes they ask 6 or 5. 3 will be the image-based question. What they want is to identify. So all the images I will share with you. You don't have to click the photo, but just try to memorize. Dermatology is mostly the image-based memorizing. So I will make this subject simple that you have to cram it less. Okay, that is the agenda. Subject is very easy to revise, and it is a prime time also. So I think what I need is, because you now only have a 55 days, right? So what I want is right that one. Okay, let's get Jai Shri Ram. Hello. Okay. Voice lagging, poor audio.
Wait for some time. Wait for some time. Wait for 2 minutes. At least give him time to start. Actually, wait. Just wait for 5 minutes.
So let's get started. I think it will pop up later. So see, in dermatology, we will be talking about mainly the 3 layers of the skin, right? What is the uppermost layer? Uppermost layer is a epidermis. Below the epidermis, I have a dermis, and the third layer is the hypodermis, which is mainly consists of the fat. Of this, they ask MCQ. Epidermis is derived from the ectoderm. Epidermis is a ectoderm derivative, whereas dermis is a mesoderm or the mesenchyme derivative. So epidermis, dermis, and the hypodermis. Yes, Jai Mata Di. Jai Mata Di. Let's rock. Okay, so let's see. This is my basement membrane. On my basement membrane, this is the layer of the epidermis, and this is the dermis. Now see this. Can you appreciate this elevation from the dermis into the epidermis? So my basement membrane is not a straight line; it is a wavy line, right? In this wavy line, these elevation are known as a dermal papillae. These elevation are known as a dermal papilla, and these depressions are known as a rete ridge. These depressions are known as a rete ridge. Okay, so finger-like projection from the dermis into the epidermis, dermal part, because this from the depressions are rete ridge, which is a epidermis. So first of all, we will discuss layers of the epidermis. We will discuss layers of the epidermis. So how you will remember? You will remember like this. Boys says, girls look कभी कभी झूठ भी बोलते हैं। कोई बात नहीं, ठीक है. So see this, what is the first layer? So what I will do, you also start from the end of your paper. We will draw all the 5 layers in the vertical form. Okay. बेटर है कि फ्रेश पेज ले लो, नीचे से चालू करके, एंड वी व्हाट आई विल डू, आई विल ड्रॉ वर्टिकली ऑल दी 5 layer and we will put important MCQ points on it. Okay. So as I told, dermis and epidermis is separated by the basement membrane. On this basement membrane, the first layer I have has a vertical cells. This vertical cell has one important protein which bind these vertical cells to the basement membrane. Anyone know what is this protein? This protein is hemidesmosome. So in which disease antibodies formed against hemidesmosome? Bullous pemphigoid. So bullous pemphigoid. So remember this important disease, bullous pemphigoid. What you will see, antibody against the hemidesmosome. You will see antibody against the hemidesmosome. So why the nature has given vertical cells in my basal layer? The reason is nature want to occupy more skin cells onto the basement membrane. Why? Because this layer, which is known as a basal layer, this basal layer is also known as a germinal layer. This layer is also known as a germinal layer or a dividing cell layer. This is a germinal layer or a dividing cell layer. As you can see, these contain columnar cells. The cells here are columnar. Important point here is this cell here has the least amount of the filament. It has the least amount of filament. Basal layer. Basal layer. So this is the first layer. Now what happens is this cell actually when they are constantly divided, they will go into the vertical upper direction in my epidermis. So what will happen here in the second layer, this cell will become polygonal shape. The reason these cells have a shape of the polygonal, the reason is it is being stretched by this spike connection, because all these cells have a spike on its surface, and because of these spikes which are present here, this layer is known as a stratum spinosum. So remember like this, because spikes are it is a spinosum. Because of this spike, this is also known as a prickle layer. This layer is also known as a prickle layer. Okay, and these spikes are are also known as a acanthos. This is spike. So it is also known as a acanthos. This is also known as a desmosome. Now, anyone know what in which disease you will see antibody against desmosome? It is a pemphigus vulgaris. Is a pemphigus vulgaris antibody is against the desmosome. So if in this disease, if they are forming antibody against desmosome, can I say it will cause acantholysis, right? Because it will rupture the desmosome, and because of the rupture of desmosome is there, I will say in pemphigus vulgaris there will be the acantholysis. Will I see acantholysis in just pemphigoid? No, because this protein is on the basement membrane, not between the two keratinocytes. Okay. After this, now this cell will go into the next third layer. The cell will become horizontal shape. And in these horizontal cells, there is a Odland body or the lamellar body. And this lamellar body will be producing granules inside and the intercellular space. And because of these granules, this layer is known as a stratum granulosum. So third layer I will be talking about the stratum granulosum, because this layer has the keratohyalin granule. Keratohyalin granules is present, which is produced by Odland or the lamellar body. It is produced by the Odland body or the lamellar body. So when we touch our skin has a slightly doggy appearance, right? It seems like there is some lipid on it, right? When we have a sweat, we feel that there is some lipid. This lipidy consistency of our skin is because of the stratum granulosum. But if you have seen any patient of psoriasis, right? In psoriasis, how are the scales? They are rough and dry, silvery scales, right? The second disease, which is a ichthyosis. In ichthyosis, also the patient has a very hard superficial skin. It is a congenital genetic disease. So typically, ichthyosis is known as they have a fish-like scale on their surface, fish-like scale. So why I am giving you this example is because in these two diseases, this layer stratum granulosum is absent, and because it is absent, the disease will look like very dry. Okay, so we will write this MCQ point that psoriasis and ichthyosis vulgaris this layer is absent. In psoriasis and ichthyosis vulgaris, this layer is absent. Okay, this layer. Now, what will happen to this cell? This cell will go into the next layer. In this layer, it will shed all the material inside and only the water content will remain. So, here in this layer, the cells of the skin shed its nucleus and only water content is present here, and because of the water content it becomes transparent, and because of this transparency this layer is known as a stratum lucidum. This stratum lucidum is only present on the palm and sole. So generally our epidermis is a 4 layer on other part of the body, but on the palm and sole we have a 5 layer. This is stratum lucidum. This stratum lucidum has a degenerated. They have a degenerated keratinocytes. It is also known as a clear zone. It is also a clear zone or a transparent zone. Now, all this watery content will be lost, and I will have a so many skin cells which are the keratinocyte with highest amount of keratin filament. So now this cell will become dehydrated, and because it loses all its water content, this cell will have highest amount of keratin, and because of the highest amount of keratin present, this layer, which is the uppermost layer, is a stratum. This layer is a stratum corneum. As you can see, this layer is a flat layer. This layer is a flat layer of the keratin. This layer has a maximum keratin present. In this layer, you will see maximum keratin. These cells are the dead cells. These cells are dead cells because they do not have nucleus. No nucleus. If you see nucleus, it is abnormal. Okay? If you see nucleus, it is abnormal. So as you can see, we started from the basement membrane. From the division of the basement membrane cells, I am sending cells to the uppermost layer. So can you say in which condition this layer will be absent? If the baby is a premature or a extremely low birth weight baby, what will happen? The cell will not reach to the uppermost layer. It will take time. So prematurity prematurity and the very low birth weight baby. This layer is absent. So these are the two examples in which you will see that this layer is absent. So this layer is very important because if you walk barefoot, suppose you have a thickness of a 0.5 mm on your sole, but if you start walking barefoot, what will happen after a few days? The thickness will increase. Why? Because this layer is very sensitive. So if a body senses that this part of the skin is bearing more weight, what this basal layer will do? On that area, basal layer will send more cell and will increase the stratum corneum. So the underlying structure, which are nerves, blood vessels, they don't get damaged. Okay, so that is why if I say hyperkeratosis means thickening of which layer? Stratum corneum. So why I am using keratin all the time? The reason is, see, if I take a one cell of the skin, first of all understand, this cell is known as a keratinocyte. This keratinocyte, why they are known as a keratinocyte? Because they have an intermediate filament like this. These intermediate filament are the keratin filament. And because of this keratin filament, these cells are known as a keratinocyte. On this keratinocyte, as I told, the second reason, which is very important, are the spikes. Why these spikes are important? Because the first strand is an inner strand, which is a keratinocyte, but two keratinocytes are bind to each other with the help of this desmosome or this spike. So, as you can see, our epidermis is not separated from the dermis. The whole time they are together. The reason is the strength of these two. If your keratin filament is strong and if your desmosomal connection is strong, what will happen? There is no gap for any other kind of fluid. But if what will happen if there is a weakness of a keratin filament? Suppose there are genetic condition which is the epidermolysis bullosa simplex. It is a genetic defect in which keratin filament itself is a weak. So because of that, what is happening? On a minor pressure, my keratinocyte collapse. Okay, so if you can see, if keratin filament is weak, see this. I'm drawing three polygonal shaped keratinocyte. First of all, understand they are tightly joined with each other. But see this, if this keratinocyte will get ruptured, what will happen? I will have some empty space, and in this empty space, what will happen? Fluid will start accumulating here. And because of this fluid, patient will present to me with some kind of a blister or a vesicle disorder. Got my point? Second reason, as I told, on all corner, desmosome is stretching this cell. And because of stretching, this cell is a polygonal shape. If my desmosome is damaged, this cell will become, because there is a fluid inside, this cell will become round shape. If I have a 2-3 cell together which has a damage to the desmosome, all this cell will become round shape, and because of this round shape, as you can see in this image, now I have an intercellular space, and in this intercellular space, fluid will accumulate, and this, because of this accumulation of the fluid, the patient will come to me that, doctor, I am having a large vesicle or a bulla on my body. Okay, so this is how this patient will present to you. So what I will do, we will discuss important dermatological terms first. Sorry, voice says well. See, no? So see, the first layer is a basal layer, spinous layer, granular layer, lucid layer, corneal layer. Hmm? Important dermatological terms. Okay, the first is hyperkeratosis. First is a hyperkeratosis. So as I told you, what is hyperkeratosis? Increase in the thickness of the first layer, which is a stratum corneum. Increase in the thickness of the stratum corneum. And as I told, this abnormality can be physiological. So, what is physiological? It is a reactive hyperkeratosis which is due to physical stress on the skin, which is generally known as a callosis. But if patient do not have any physical stress on the skin and still he is developing the thickening of the superficial layer, which is stratum corneum, it is seen in a classical example, psoriasis. It is also seen with the lichen planus. It is seen with the psoriasis. It is seen with the lichen planus. It is also seen with the Darier's disease. The next term is the parakeratosis. In parakeratosis, as I told you, my cell is in the basal layer, and from the basal layer, first of all, understand this. This basal layer cell, as I told, when reaches to the uppermost layer, it loses its nucleus, right? So generally, we started from here least amount of keratin. We started here with the least amount of keratin in the upper layer, which is a stratum corneum. It is the highest keratin, right? This process is known as a keratinization. This process is known as a keratinization, and in this keratinization, the normally period is a 28 days. It is a 28 days. But now, what happens? In psoriasis, this epidermis turnover time, epidermis turnover. So why I am telling this time is the epidermis turnover? Because when this cell will come into the stratum corneum with daily routine, I will be using this stratum corneum, right? When we will take bath, we are sitting because of the friction. I am losing the cell, but along with that, I am receiving the cell from the basal layer also. So this time is also known as the epidermis turnover time. But if my basal layer is working too much and sending too much skin to the upper layer, what I will have? I will have an abnormal skin because basal layer is sending too much skin. So this happens in psoriasis, that epidermis turnover time reduces to 6 to 8 days. So there is no specific time, but what I am trying to say, it is reduced. So what is happening when this cell reaching to the uppermost layer, I will see some of the cells are retaining its nucleus. The reason they retain the nucleus is cell become too early onto the surface. So because of this retention of nuclei, in the uppermost layer, retention of nuclei in the uppermost layer is known as a parakeratosis. And this parakeratosis is always pathological. It is a feature of psoriasis. It is a feature of actinic keratosis. It is also the feature of actinic keratosis. So here you can remember other pathology also. Generally, keratinocyte cell cycle is approximately 311 hours. The cell cycles of keratinocyte is 311 hours. In psoriasis, the cell cycle time is reduced to nearly 36 hours. To 311 hours. So G1, G0, G2 phase, right? So this is generally 311 hours. Yes. Okay, turnover. See this. So what is the turnover? So as I told, from the basal layer, cells are coming into the uppermost layer. So daily I am taking my bath, we are wearing clothes, we are playing. So our skin is always having a friction. And because of the friction, I will be losing the cells, right? But I'm losing the cell, but at the same time, I'm receiving the new cell from the basal layer. So it is a constant upgoing. From the basal layer, those cells are constantly coming. It generally takes 28 days. Some older textbook says it was a time of 56 days. But it is not just a single answer. But for your exam point of view, I am telling that it is a new answer as a 28 days 4 week. What happens in psoriasis? In psoriasis, basal layer is dividing too much fast because of the autoimmune reaction. And because of this, patient has a too much skin coming up. So that skin is a problematic because too much skin is coming up. So this is an epidermis turnover. In this turnover, the second thing happening is least amount of keratin is present in the basal layer. But when I reach to the uppermost layer, the cells will become dehydrated and the highest amount of keratin will be present in the uppermost layer.
So, why is this not a pre-malignant condition?
Which one? Psoriasis. It is not a which is not a pre-malignant. Actinic keratosis is a pre-malignant condition. But psoriasis is not a pre-malignant condition. The reason is it is a transient autoimmunity. It is not a persistent. But actinic keratosis, the second disease we wrote. So in this disease, what is happening is there is a constant stimulation and the constant reduction of the time of the cells. They are rapidly dividing. But if this patient has a constant exposure to the sun, this is not commonly seen in our country, but who has a less protection against the UV light, their cells because of the sun divide too much, and we will learn it later that actinic keratosis can lead to one important cancer, which is squamous cell carcinoma of the skin. Okay, actinic keratosis is a risk factor for the squamous cell carcinoma of the skin. Okay, the third is a hypergranulosis. Third is hypergranulosis. It is an increase in the thickness of the stratum granulosum. Okay, hypergranulosis, stratum granulosum. Very important disease. In lichen planus, you will see hypergranulosis. And because of this hypergranulosis, multiple time MCQ has been asked, the classical feature is known as a weekend stria. Classical feature is known as a weekend stria. So generally in your MCQ, they will write like this. They have a white criss-cross lines on the lichen planus papules. So weekend stria is due to hypergranulosis. Next term is a spongiosis. In a spongiosis, you remember our skin okay. See, in spongiosis, our skin generally gives a protection because when we use soap, when we use rub, everything, right? So we are constantly coming in contact with some kind of acid or some kind of alkali. Either they are mild or strong. But not all this causes the dermatitis. The reason is our skin provides the protection. And this protection is like a cement and brick model. But what is happening if this barrier is impaired? If this barrier is impaired, what will happen? Irritant can enter and cause the inflammation of our cells. And if they start inflammation, what I will have? I will have an intercellular edema. The reason is because of the irritant entered into the deeper layer. So this intercellular edema is known as a spongiosis. This is a spongiosis. Spongiosis is intercellular edema. So, in which condition barrier is impaired? Barrier is impaired in eczematous dermatitis, or do not get confused. This eczematous dermatitis is also known as the atopic dermatitis. Now, the term is being used for the same disease, eczema or the atopic dermatitis. So the MCQ was asked, which layer is mostly affected? Answer will be the stratum spinosum is most commonly affected. The reason is the upper layer, which is the stratum corneum, and from the stratum corneum granulosum, they are horizontal, and they have a less fluid. But the stratum spinosum has a more fluid. If there is an inflammation, the fluid will leak out from the spinous layer mainly. So intercellular edema, it affects spinosum layer commonly. Fifth term, very important, acantholysis. Acantholysis. In a general term, acantholysis is separation of epidermal cells. It is a separation of epidermal cells. So why there is a separation of the epidermal cell is in pemphigus vulgaris or any disease which produce antibody against the desmosome. When they rupture this desmosome, what will happen? These cells become round. This cell will become round shaped. And because of this gap increase between two cells, a fluid will start accumulating around it. And because of this fluid accumulation, patient will develop blister. Patient will develop blister. So what happened here is, because there is an antibody against the desmosome, what happened? Desmosome damaged first, and then patient developed the blister. This is the primary acantholysis. This is the primary acantholysis. So I will see acantholysis in all the diseases in which there is a antibody against the desmosome. So what are the examples in which antibody is formed against desmosome? These are the pemphigus, vulgaris, pemphigus, foliaceus. If person develops impetigo, what is the causative agent of impetigo? Yes, it is a staph aureus. When this disease is caused by the Staphylococcus aureus, listen carefully. These Staphylococcus aureus produce one toxin, which is a epidermolytic toxin, and these epidermolytic toxin, when they directly damage the desmosome, I will have a acantholysis. And what is this complication known as? If a patient of impetigo, it is known as a staphylococcal scalded skin syndrome. Staphylococcal scalded skin syndrome. Click around. It is a staphylococcal scalded skin syndrome. It is a staphylococcal scalded skin syndrome. तो यहाँ पे आपको तीन चीजें अच्छे से याद रखनी है. Impetigo, what is the causative agent? Staphylococcus aureus. Which toxin is produced? Epidermolytic toxin. And this epidermolytic toxin will damage my desmosome, will cause acantholysis, and the disease is known as a staphylococcal scalded skin syndrome. We will discuss this later in detail also. The third disease which shows acantholysis, which is a primary, is a Darier's disease. Darier's disease and the Haley disease. Darier's disease and the Haley disease. I'm giving you the point is, both this disease has a calcium pump defect. Pathogenesis थोड़ी से ना, calcium pump defect, because desmosome require calcium for the tight connection. If they are weak, what will happen? The cell will get separated, right? So Darier's disease and the Haley disease, the diseases are different. We will discuss it later. But what I'm trying to say is, because of the calcium pump defect, they have a very weak desmosome. And because of this weak desmosome, they will show primary acantholysis. They will show primary acantholysis. Okay. Sure. Now, what is secondary acantholysis? acantholysis terminology चल रही ना, acantholysis primary and secondary. So see this, what is secondary acantholysis? So first of all understand, this is my polygonal shaped cells. As I told you, if this cell is get infected by the virus, right? This cell is not separated from the other keratinocyte. They are tightly attached. But what happened is, these two cells got infected with the virus. And because of this infection caused ballooning degeneration. They cause ballooning degeneration of the cell. And because of this, what will happen? The cell is becoming round because of the excessive fluid inside it. Okay? So cells are not able to hold the polygonal shape and they lose its connection with desmosome. And cells become round. And cells become round. Generally, this viral infection, which is commonly caused, this is a herpes virus, and that is why in chickenpox you see fluid-filled vesicle, right? A fluid will start accumulating between this, and because of this extra fluid, patient is presenting with the vesicles. These cells, in microbiology, you all know, these are the giant cells which are known as giant cells. These are the multinucleated. This will become multinucleated giant cells, and that is why you all know in microbiology we always look for Zinc smear. Yes, this is a diagnostic test. But now tell me, Zinc smear will be positive only in secondary acantholysis or it will be positive in the primary acantholysis also? It is all. So you cannot differentiate with the Zinc smear that it is a primary acantholysis or a secondary acantholysis. So, classical fluid field. जैसे herpes में हाँ bulla is large size. I will show you the photo so you will get some. Okay. So this was about the acantholysis. So let's discuss acanthosis. Fifth, acanthosis. So now you can understand acanthosis means increase in thickness of which layer? Acanthosis means increase in the thickness of the stratum spinosum. So any disease you know with acanthosis, the acanthosis nigricans, right? The important disease, acanthosis nigricans. Acanthosis can also be the feature of psoriasis. Okay, so these are the example. ओके चलो थोड़ा दिमाग चला लो अब, है ना? आंसर कर दो फटाफट. करेक्ट सीक्वेंस ऑफ द लेयर्स ऑफ द एपिडर्मिस. व्हाट यू विल आंसर?
D.
Basal, spinosum, granulosum, lucidum, and corneum. What you will answer? You will answer. Answer is P. So see this graphical representation of the skin. As I told you, the first layer is a stratum basal layer. What was the important feature here? This basal layer are the bind with the which protein? Hemidesmosome. Which disease? Bullous pemphigoid. So bullous pemphigoid is the disease. Now along with that you see this melanocyte. So if I ask you melanocyte is present in which layer? Basal layer. Because it is present among the basal layer. Okay. Least amount of keratin in the stratum basal layer. Second is the spinosome. It has a spike, right? What are these spike? These are the spike of the desmosome. So if I say in acantholysis, which layer is affected? Stratum spinosum is affected, right? Coming to the stratum granulosum, keratohyalin granule produced by which body? Ordline body or the lamellar body. In hypergranulosis is a feature of lichen planus. Lichen stria. Remember hypergranulosis. This layer is absent in which two disease? Psoriasis, ichthyosis, vulgaris. Stratum lucidum, transparent layer, only present on the palm and sole. Stratum corneum, uppermost layer, highest amount of keratin, absent in which two condition? Prematurity and very low birth weight. These cells are anucleated cell. If I see the nucleus, parakeratosis, which two condition? Psoriasis, actinic keratosis. As I told, actinic keratosis is a pre-malignant condition of a squamous cell carcinoma. If I say hyperkeratosis, it is a thickening of the uppermost layer, stratum corneum. What are the two examples? Callosis and the psoriasis. Remember two examples. It is also seen in the lichen planus. My cell from the basal layer going into the uppermost layer in how many days? 28 days. So this time is a epidermis turnover time. Reduced in which disease? Psoriasis. It is reduced in psoriasis. So now you can answer which layer of epidermis is underdeveloped in very low birth weight infant? Very low birth weight will be stratum corneum will be. Desmosome. अरे keratinocyte ना. Hemidesmosome is helpful in connecting dermis and the epidermis, but desmosome is helpful in connecting two keratinocytes. Okay. See this first of all. So someone was asking what is a vesicle and bulla. So I will show you some photo. So first of all, let's see how we term these patches is. See, If I have a hyperpigmented flat lesion or a hypopigmented flat lesion, what are these? I will come. ये लिखने की जरूरत नहीं है, इसमें MCQ नहीं आता. Okay, so it is just for the understanding. What is macule? What is patch? What is macule? Macule when I have a hyperpigmented flat lesion which is not above the skin. So it is not in the filling when I'm rubbing the skin. It is not in my fill. So these are the flat lesion. So what I will say, as in this patient, what I will say, this patient is having a hyperpigmented macule on his nasolabial fold. But if this size is more than 1 centimeter, so what I will say, hyperpigmented or hypopigmented patch on a particular area. Okay, so macule and patch. So because sometimes what will happen is they will give you a clinical question without any photo, right? So this term should be clear in your mind because you will have seen the photo of the disease. So you have to know what is the description. Okay. So this is a macule, this is a patch. The term is they are flat. Okay. Now coming to that papule and plaque. What is papule? They are raised lesion above the skin. Papule, if it is less than 1 centimeter. Plaque, it is more than 1 centimeter. So this is papule because this is in the larger area. It is a plaque. Now, in many diseases, you all know, in most of the disease of exanthem, what we write? We write maculopapular rash. Maculopapular means some lesions are flat, some are raised. This rash is sometimes termed as a morbilliform rash also. Okay. Now what is vesicle? What is bulla? Vesicle means fluid-filled lesion. But if it is less than 1 centimeter, I will term it as a vesicle. Chote sa. But if it is a more than 1 centimeter, so this is a bulla. But the thing is, what I am trying to say, the content inside is a clear fluid. If size is the same, but if I see the pus inside it, what I will term? I will term it as a pustule. Vesicle as a clear liquid, pustule as a pus. What is a wheal? Wheal or urticaria. It is a dermal edema. It is a dermal edema. What is scale? So you all know when we have a superficial fungal infection, we generally itch. And when we itch, what will happen? The superficial skin will come out. So when we have a fall, after some days there is a superficial scab, right? And this scab will come out. So this scab, which is formed because of the primary intention of wound healing, this superficial area which will come out and pathologic, it is known as a scale. So what is a scale? It is a peeling or the flaking of the stratum corneum. Because of any reason, if I am itching my skin, what I am doing? I am removing the stratum corneum. It is most commonly seen in the fungal disease. Why? Because our skin cell release cytokine. And this fungus infect our superficial layer. Why they infect our superficial layer? Because they want to eat keratin. They are keratophilic. Why fungus infect us? They infect us to eat our keratin. So what they will infect? They will infect our skin, they will infect our nail, they will infect our hair. तो डैंड्रफ होता है ना, क्यों होता है? फंगस बढ़ जाती है. क्यों? क्योंकि फंगस तो यूनिवर्सल है, हर जगह पे है. But in an area where there is a two type of fungus is there. Some fungus are the keratophilic, some fungus are the lipophilic. Sebum khate. But the fungus which eats keratin. So when they are infecting our stratum corneum, what our skin cell will do? They will release cytokine, and with the cytokine release, the protective mechanism, what we will do? We will itch. And because of the itch, what I am doing? I am removing the area of the infection from the stratum corneum. So it is just a primary prevention body is giving to you. So anytime you come into some pathogen, our Langerhans cell, which is the immune cell present in the superficial layer, it just come to that area and tell us that this is the pathogen, this is a foreign body, right? So this is known as a scale. So remember scale, we will talk about scale in every disease, psoriasis, pityriasis, versicolor, pityriasis rosea. We will be talking about the scale. So you should not get confused what is the scale, okay? Next is a crust. So when we have a pustule, you all have seen when we develop any skin lesion with a pus formation, this pus will either come out of our body. In abscess, what we do? In abscess, we drain it into the outer surface. But if this on the surface only, it will dry out. And when it dry out, it is known as a crust. Okay, this is known as a crust. So in your exam, one important question was asked, honey colored crust. I will show you the photo. So fissure, erosion and the ulcer. What is the difference? Fissure is a cut through the epidermis and dermis. Erosion mainly involves the epidermis. Ulcer can involve both epidermis and dermis. Okay, now see this. See this first. What you will term it? Macule, papule. It is a macule. It is a flat lesion, no? It is a macule. Second, is it above the skin? No, it is flat, but it is more than 1 centimeter. So what is it? It is a patch. Now tell me about the C. Can you see the fluid inside it? No, there is no fluid. It is just a swelling papule. It is a papule. Sorry? Papule. जैसे suppose करो ये acne की papule है. So what is happening in acne? Our immune cell is coming. Immune cell is coming there and try to destroy the propionibacterium acne, which transmigrated underneath the epidermis. So because of our inflammatory reaction, there is a swelling, but there is no fluid accumulation up to now. So there are three things. This nodule can be because of the obstruction of the gland, because all our skin has a glands, right? Sebaceous gland, pilosebaceous gland, and the apocrine gland in the axilla and the perineus. So if it got obstructed, we can develop a papule. So there are many reasons for developing papule, but this is look like a papule of the acne. Now, tell me about the D. How you will term it? Plaque. It is above the skin. As you can see, there are many scales coming out here. So these are the superficial dead epidermis skin, right? Now E. Vesicle है ना ये? These are the vesicle. Less than 1 centimeter जैसा लग रहा है. Fluid क्या है? Clear fluid. Okay. Pulla. G. What you will term? Pustule. This. Wheel or urticaria. Wheel or urticaria. Crust. Crust समझ लो या फिर स्केल समझ लो. ये दिखा क्रस्ट का क्लासिक एग्जांपल ये दिखा रहा हूं मैं. ये क्रस्ट है. What this is a scale because of the dried out skin. So this is because of the psoriasis. Okay. So dead skin just accumulating on the upper area. But this is a classical example of crust. As I told, honey colored crust. Right? So this image-based question, multiple times this one-liner has been asked, honey colored crust. Honey colored crust is because of the bullous impetigo. Person has a extensive infection with the pus formation, and this pus dried out. And when this dried out, it caused this honey colored crust appearance. What is the disease? It is a impetigo. What is the causative agent? Staphylococcus aureus. What was the important complication of this? Staphylococcal scalded skin syndrome. Staphylococcal scalded skin syndrome. Okay, एक दो आंसर दे दो फिर नेक्स्ट टॉपिक पढ़ते हैं. Acantholysis is seen in what you will answer? It is a epidermis. इन दोनों का आंसर दे. Spongiosis involves which layer? Stratum spinosum. Spinosum. Acanthosis involves इसका A and B both, right? A and B. A and B both. We will discuss epidermal cells. The first cell is a keratinocyte. In our total skin, this keratinocyte is comprised of 95%. So most of the cells are the keratinocyte. The intermediate filament is present, which is a keratin filament. This intermediate filament is a keratin filament. Transit time or the turnover time is 28 days. This keratin filament has one protein which connects this all keratin filament. This protein connecting this keratin filament is known as the filaggrin protein. This protein is a filaggrin protein. And together, this keratinocyte is provide important barrier function. Provide important barrier function. Second important cells are the melanocytes. Melanocytes. So where are the melanocytes present? They are present in the basal layer. They are present in the basal layer. They are derived from neural crest. They are derived from the neural crest. These cells synthesize melanin from which amino acid? Melanin is produced from which amino acid? Tyrosine. It is produced from the tyrosine. Which enzyme is required? Any disease in which tyrosine is absent? Albinism, right? In albinism, tyrosine is absent. So tyrosine amino acid is present, but cell will not be able to make melanin. So patient will have a whole body depigmentation. So synthesize melanin from the tyrosine amino acid with the help of tyrosinase enzyme. So what is the use of this melanin? It is pigmenting our skin. Along with that, it is providing the protection also. So protect against UV light. And because of this, in India, we do not have a commonly a skin cancer disease. Okay, that is why. So the Indians have type 5 skin, most common. On which scale? Feeds Patrick scale. Why? So what is this scale? This scale is assessment of the risk of the skin cancer. So they have seen that if you have a black skin, there are less chances of developing skin cancer. Indians have a type 5 skin, most common on a Fitzpatrick scale. So see this melanocyte. So how they produce melanin? So it is a function of melanocyte to produce melanin, but what they will do? They will package this melanin into a large melanosome. This packaging are known as a melanosome. And with the help of this dendrite, it will send this melanosome to a keratinocyte. This keratinocyte will take up this melanosome and now it will open this package and pigment itself. And this pigment will be dispersed throughout the keratinocyte and person will have a particular skin color, hair color, iris color, all because of this melanosome. So melanin is not directly transferred to the keratinocyte, it will be transferred in the package of melanosome. Now tell me, if a person is having the same number of melanocytes, can they have a different color of body? Suppose I have a 1000 melanocyte on my body and he is also having a 1000 melanocyte. So is it depend on a number of melanocytes that we will have a same color? No. It depends on how my melanocyte is functioning. Suppose I have a 1000 melanocyte, but if my melanocytes are functioning too much, like they are making a large melanosome and giving this large melanosome to one keratinocyte in a very large number. Suppose one keratinocyte is receiving at least 5 melanosomes from the melanocyte. So what will happen? I will have a dark skin. But in other person, if the melanocyte is making a very less or a small size melanosome, what will happen? The transfer will be low and this person will develop a fair skin. So write down this: skin color depend on a amount of melanin produced, number and the size of the melanosome, and the degree of transfer. Because in one of the MCQ, this sentence was given, which is not true. It do not depend on the number of melanocytes. It depends on these three structure and do not depend on the number. No, what I'm saying is skin color depend on amount of melanin produced, right? The example I give. So see this, no? See this. See this example. In this girl, I have one melanocyte. In this boy also one melanocyte. But what is the degree of transfer? If I zoom it, see this. All this keratinocyte is receiving 3 melanosomes of a small size which has a very less melanin. But in this boy who is receiving at least, you see, there are many melanosomes received by this, but the content of the melanosome is also the higher. There are more melanin inside. So what will happen to this person? This person will have a black skin, but comparatively girl will have a lighter skin, fair skin, right? So it do not depend on the number of melanocytes. Okay, here you remember one important point: ultraviolet B light. When we have a ultraviolet B light, remember B for the burn. On our skin, generally ultraviolet B light causes the skin burns. It is a 290 to 320 nanometer. And the UVA light, it causes skin tanning. Skin tanning is because of the UVA light. It is 320 to 400 nanometer. Why? Because, as I told, these cells are present on the basal layer. This UV light, because of the higher wavelength, can penetrate more through my epidermis and can stimulate this melanocyte. But this UVB light will remain into the upper layer only, and because in the fair skin person, if they go into the sun, what will happen? They will develop skin burn. But we Indian will not develop skin burn. What we will develop? We will develop a skin tanning. The reason is we have the protection against skin burn. We have a melanin layer. But because of this, what will happen? We will stimulate our melanocyte very quickly, and very quickly we will develop a skin tanning. And that is why क्रीम्स हमारे यहाँ ज्यादा यूज होती है ना, सनस्क्रीन्स ज्यादा यूज होते हैं. द रीजन इज बिकॉज वी टेंड टू डेवलप अ मोर टैनिंग because of the sun. Okay, so see this is a Fitzpatrick scale. As I told, we Indians have a type 5 skin, and it is just we have a protection against the skin cancer. Okay, we will discuss important disorders of the melanin. Disorders of the melanin. So what we will do? We will learn first of all hypopigmentation disorder and then hyperpigmentation disorder. So disorder of hypopigmentation. So I will take first genetic conditions first. Here you understand how they ask the MCQ. See this, as I told you, melanin is produced from the tyrosine amino acid with the use of the enzyme tyrosinase. And this tyrosinase is absent in the disease albinism. So if I take a patient's skin, if I take a biopsy, what I will notice that there is a melanocyte is present, but this melanocyte is not able to make melanin, right? So generally they ask MCQ like this: in albinism, what is present, what is absent? So what is present in albinism? Melanocyte is present, melanin is absent because enzyme is absent. And what is the disease they ask? It is an autosomal recessive disease. So 3 things you should remember. Next disease, which is an acquired condition. In this acquired condition, this is a vitiligo. Vitiligo is an autoimmune condition. What happens in vitiligo? My own Langerhans cells will kill this melanocyte, will attack this melanocyte and will destroy. So what will happen in particular area? Suppose in my arm, there are too much destruction of the melanocyte. What will happen? There is no pigmentation of the melanocyte. So when in just 28 days, when all the skin is coming up, what will happen? They are not receiving any kind of melanin from the melanocyte. So what will I develop? I will develop a depigmented white patch because skin is coming up, but they are not receiving the melanin from the melanocyte. So if I see this in this patient example, if I take a biopsy from this area, what I will notice that in this area there is no melanocyte, there is no melanin. But if I take from the normal area where autoimmunity has not killed the virus or not killed the melanocyte, I will see melanocyte present. I will see there is melanin present. But in the affected area, there is no melanocyte. Okay. So having said that, we will discuss the first disease, which is the albinism. From the albinism, remember this genetic condition, it is an autosomal recessive disease. In your exam, if they ask about what is autosomal dominant, autosomal recessive, ये लिखना नहीं है, हम लिखेंगे, ये खाली समझने के लिए हम लिखेंगे. पहले हम जेनेटिक कंडीशन लिखेंगे, फिर एक्वायर्ड लिखेंगे. So see this, in albinism, what I was telling you is, if you have to do an intelligent guess, what you will do, any enzyme deficiency is most likely will be the autosomal recessive. So if you see the list of autosomal recessive diseases, most of the diseases will have an enzyme deficiency. But the disease which has a cytoskeleton defect, they will be the autosomal dominant defect. Okay? So when you go through this list, you can remember like this: cytoskeleton defect or a proper defect in which there is a body is affected directly, physical structure is affected. These diseases will be inherited as an autosomal dominant condition. But enzyme deficiency are most commonly as an autosomal recessive condition. Here you will see tyrosinase enzyme absence. So because this enzyme is absent, patient will have a diffuse depigmentation, So skin, hair, or even the iris color is affected. Skin, hair, and iris color is affected. What can be the side effect of this disease? Yes, they have a increased risk of skin cancer. Okay, so this is the albinism. Second is a PA baldism. So see this characteristic image. Two things you should remember in this, that in this disease, PA baldism, anterior forelock is commonly seen affected. And the second is what you will see in the depigmented skin. You will see that some area of the normal skin is also present. As you can see in this patient, these are the area of the normal skin present. On the leg also, you can see there are the areas which involves the normal skin. So what is happening in PA baldism? Two things you should have to remember. In PA baldism, it is a autosomal dominant defect. Why autosomal dominant defect? As I told you, melanocytes are derived from neural crest. So you all know the cells which are derived from the neural crest during the embryogenesis, they migrate. They migrate and they reach to the normal place. You all know Hirschsprung disease, which is also the disease of the abnormal neural crest migration. Cells didn't reach to that place. Similarly, in PA baldism, melanocytes are derived from the neural crest. So, in this particular skin area, there is permanent no migration of the melanocyte. But what you can see, there are some area, but these areas are not large. These are just a 1 to 2 centimeter area which has a melanocyte present. But as you can see in the larger area, there is no melanocyte. So this is an autosomal dominant defect and it is a neural crest migration defect. Two important things and image-based question you should remember on this. It is an autosomal dominant with abnormal. It is a abnormal neural crest migration. Autosomal dominant abnormal neural crest migration. Localized depigmented. You will see localized depigmented white patch with the area of normal skin present. With the area of normal skin present. White forelock is commonly seen. So you will see that hair color is affected in this area. Hair color is also affected in this area. Now, see this next condition. We will be learning about the two important nevi. One is a nevus depigmentosus and the second is nevus anemicus. First of all, understand both have a similar appearance. As you can see in this appearance, so these are the condition which you can see in the newborn. Okay, after a few days, after somewhat around 1 month, you will notice that this person is having some depigmented patch on his body. So mother might be concerned that is my child is having a vitiligo, right? So she might be concerned. In India, it is always mother have a concern of these diseases, right? So what will happen? This is a nevus depigmentosus. As the name is telling you, depigmentosus, there is depigmentation. So pigmentation means increased, depigmentation means decreased, right? So this nevi is because of that somewhat depigmentation. So what is happening in this nevi is underlying, suppose this melanocyte, but this melanocyte is sending some, because of some defect in this area, this melanocyte is sending less melanin or melanosome, and because of this, naturally this particular 1 to 2 centimeter area is having a less pigmentation comparing to the other area of the skin. So that is why this area looks like a depigmented area, but it is a defect in the melanocyte, that whatever melanocyte will generate from this area, it will cause a depigmentation. Okay, so it will be the slightly paler. It will be slightly paler than the rest of the skin. So this nevus is a nevus depigmentosus. Second is a nevus anemicus. So you all know in anemia what we say, skin pallor is present, right? Second example I will give you. You all know Raynaud's phenomena. In Raynaud's phenomena, what happened? WBR, white BR. Your skin will become white, means pale. Then it will develop a cyanosis. Then you will have a vasodilation and again the reperfusion. So your hand will become again red, which will be more red than the previous. So generally I tell the students to remember like this, WBR in Raynaud phenomena. So why they develop white color? Because of the severe vasoconstriction. They have a sensitivity towards the cold. So they develop a severe vasoconstriction, and because of that, their hand become very pale, whitish. So similarly, what happens in nevus anemicus is, in nevus anemicus, they have an underlying skin defect. So suppose if I draw a skin vessel passing from this area, this vessel in this area, because of the vessel defect, extremely become constricted, and because of this extreme constriction, this some area is look like a pale color. Got my point? But the only MCQ they ask on this point, why I am taking this topic is, they ask is, what is the difference on the diascopy? So what is the difference on diascopy and what is the method of diascopy? In diascopy, what I do is, I will take a glass slide. I will press this lesion, both these lesions, nevus depigmentosus and nevus anemicus. And with the help of the glass slide, I will take a glass slide like this and I will press on. So what will happen in nevus depigmentosus? Because the border is made up of the color, it is just an underlying skin color. So this border will not change. Even after I press it, this border will not change in nevus depigmentosus. But you all know vessels are the superficial structure. If this area has a vessel defect, if you are suppressing this vessel, you will also see a slightly similar color because the pathogenesis is the same. So you create pathogenesis here. This was the congenital. So what will happen on a diascopy? The lesion border will change in nevus anemicus. So this is the point you should remember. Okay. So write down in nevus depigmentosus. In nevus depigmentosus, is a congenital defect. It is a congenital defect of pigmentation versus nevus as a blood vessel defect. How to differentiate? I will use this method, diascopy. On the diascopy, when I press with the glass slide, if in your exam you are asked border is not lost, it is a nevus depigmentosus. It is a nevus depigmentosus. But in nevus anemicus, there will be the change of the border. What I will notice that there is a change of the border. This is a nevus anemicus. ऊपर का करना है. What is the most common cause of the Raynaud's phenomena? Most common cause of the Raynaud's phenomena? It's idiopathic. Most common is a idiopathic. This MCQ has been asked. Okay. Which collagen vascular disease associated with the Raynaud's phenomena? Collagen vascular disease. कोलाजन वस्कुलर डिजीज बोल रहा हूँ ना. इडियोपैथिक का मतलब क्या है? What is the meaning of idiopathic? Not known. Most of the time we will not be able to find the cause. But if I telling you which collagen vascular disease can have a Raynaud's phenomena, it is a scleroderma. Why? Because in the blood vessel there is a collagen deposition, and because of the collagen deposition there will be the more vasoconstriction. Okay, more vasoconstriction. What is the drug of choice of Raynaud's phenomena? Drugs देते हैं ना. If they ask you as a one-liner, so there are many, but for your exam point of view, remember in Raynaud's phenomena, drug of choice is a calcium channel blocker. Calcium channel blocker as a drug, or if you want to apply topically, it is a nitroglycerin cream. Which is a nitroglycerin, you all know, it is a vasodilator. So topically you can apply nitroglycerin. Okay, you can also take it as a tablet, but topically you can apply, because what happens in scleroderma, person will develop ulcer because of a severe vasoconstriction. So Raynaud's phenomena, remember, it is an important topic. You should know this. Okay, these 3-4 MCQ on Raynaud's phenomena are important. You should know this. Okay. See this. We will discuss now acquired depigmentation disorder, nitroglycerin. Most common disorder which is associated with the vitiligo? It is a most commonly a thyroid disease. Okay, why? Because always remember, a disease which is a autoimmune will have a other autoimmune disease also in the body. Because why the person develop thyroid disease? He developed thyroid disease. The reason is his immunity is working against own cell. You all know 80% of the hypothyroid patient, what is the cause? Hashimoto thyroiditis. It is because of the autoimmune. Which antibody? Anti-myeloperoxidase antibody, right? So anti-myeloperoxidase antibody or anti-thyroglobulin antibody. Our follicles are attacked in Hashimoto thyroiditis, and person is developing this disease. Along with that, most commonly thyroid patient also will have a B12 deficiency. What can be the cause? If a thyroid patient coming to you with a severe B12 deficiency, he is having a which anemia? Pernicious anemia. He is having a pernicious anemia. So why I am taking this point is vitiligo is also an autoimmune condition, and all other autoimmune diseases can be associated with this. So what is the Addison's disease? It is a hypo or hyperaldosteronism. It is a hypo. What happens in Addison's disease? My autoimmune destroys the adrenal cortex. Because it destroys the adrenal cortex, I will have a hypoaldosteronism. In diabetes insipidus and diabetes mellitus, you all know in type 1 diabetes, there is an autoimmune destruction of the type 1 beta cells, right? So, beta cell destruction is associated with the diabetes mellitus type 1, okay? So, which is seen in a children, right? So, these all are the autoimmune condition can be associated with the vitiligo. We will write down few important points on the vitiligo. Vitiligo is an autoimmune. Vitiligo is an autoimmune in the affected area. In the affected area, no melanocyte, and no melanin is present. This disease is associated with most commonly thyroid disease. It can be associated with the diabetes, it can be associated with the Addison's disease, pernicious anemia. Pernicious anemia. Which antibody you will see in pernicious anemia? Because anti-intrinsic factor antibodies, okay, which will cause type A gastritis, right? Type A gastritis. So it will cause B12 deficiency because of the anti-intrinsic factor. It has an anti-intrinsic factor antibody. It will cause autoimmune gastritis. which is a type A. So remember like this, A for autoimmune, A for autoimmune. So you will remember type B also. Type B gastritis is H. pylori. B for bacteria. B for bacteria. Okay. Vitiligo shows positive Koebner phenomena. Positive Koebner phenomena. This is also known as a isomorphic phenomena. So here remember, it is seen in psoriasis. It is seen in the lichen planus. It is seen in psoriasis. It is seen in the lichen planus. So suppose this is a patch of the vitiligo. If I have a linear trauma, after some days on the line of my scratch, a new lesion will develop. This new lesion is like the primary lesion, and because of this, it is known as a isomorphic phenomena. Suppose this is the patch of the vitiligo. Okay, I'm giving you an example. I have a tiny patch of the vitiligo, but now I cause the linear trauma on this. Because of the linear trauma, initially I did not have a patch on that area, but when I did the linear trauma, what I caused is I triggered. This was the autoimmunity, right? This was because of the autoimmunity, no? This patch was because of the autoimmunity. But when I caused the linear trauma, what happened? I triggered the autoimmunity on this healthy skin also. And because of this, after some day, I see that there is increase in the lesion. So, and this lesion will be the similar like the previous lesion. So this is known as a Koebner phenomena or the isomorphic phenomena, because the lesion which are formed are similar to the previous one. So as I told you, it will be seen in the autoimmune conditions. What are these autoimmune conditions? Psoriasis is autoimmune condition. Lichen planus is also autoimmune condition. It is seen in a psoriasis and lichen planus. Okay, what can lead to the poor prognosis? In the vitiligo, what are the factors which can lead to the poor prognosis in the vitiligo? So if person has a thyroid disease also, if the thyroid disease is present, if hair is involved, which is known as a leukotrichia. Hair involvement is known as a leukotrichia. If lip tip is involved, leukotrichia. if lip area or lip borders are involved, then it will be very difficult to control this disease. And if the lesions are on the bony prominence, if lesions are on the bony prominence, it will be difficult to control. So, if I ask you what is the most common type of the vitiligo, so in dermatology, when you are solving the MCQ, anything most common in dermatology are the vulgaris. So, most common is the vitiligo. Vulgaris. Sorry?
How many types of vitiligo are there?
How many times vitiligo? Oh, vitiligo. Vitiligo देखो सेगमेंटल होता है, लीनियर होता है, एक डर्माटोमल डिस्ट्रीब्यूशन पे होता है, एक होता है कि भाई बॉडी प्रोमिनेंस पे ही होगा, एक होता है कि सेगमेंटल लाइन पे ही होगा, तो ऐसे और डिफ्यूज होता है. सो डिफ्यूज उनको होता है जिनको मतलब सारी बॉडी की स्किन इन्वॉल्व हो गई, और किसी को लोकलाइज भी हो गया, मतलब यहाँ एल्बो से आगे नहीं बढ़ रहा, पूरे शरीर पे नहीं होगा, या फिर किसी फिंगर पे ही आया. सो लोकलाइज्ड होता है और जनरलाइज्ड होता है इन अ ब्रॉड वे. सिमेट्रिकल होता है, एसिमेट्रिकल होता है, फिर जनरलाइज्ड होता है. सो माइनी क्लासिफिकेशन. सो दे आर नॉट गोइंग टू आस्क यू दिस, बट दे विटिलिगो वल्गारिस इज द मोस्ट कॉमन. Okay, now coming to the treatment part. So in a treatment, what we have to understand is what we will do. What is the main pathology here? Autoimmune destruction of the melanocyte. So what I have to do? I have to suppress the immunity. So the first is the immunosuppressive. Can use topical steroids. I can use when there is a less than 20 body surface area is involved. Even in the Cushing's, you all know the stria which develops on the abdominal skin. It is because of the extreme thinning of the skin. Similarly, when you apply topically, it will cause the thinning of the skin. And because of this, doctors do not recommend steroid application on the face skin, because our face skin is relatively thinner comparatively to the other part of the skin. So that is why these are contraindicated on face. Not pure contraindicated, but we should avoid, because a female will have a cracking, male have a slightly thicker, but female will have a more cracking of the skin. So what is on the face drug of choice? So it is better to apply, if the face area is involved, better to apply drug of choice tacrolimus. So these are the topical. After the steroids, the next is a vitamin D derivatives. Which is a calcipotriol cream. So at this point, phototherapy is very useful. In the phototherapy, we will use ultraviolet light. And as I already told, ultraviolet light stimulate melanocytes. It stimulates the melanocyte. It reduces reactive Langerhans cells. Okay. And it also reduces lymphocyte migration in that particular area. So as you can understand that is why UV light is helpful, because it will stimulate the melanocyte. It will reduces the autoimmunity in that area. So what will happen after giving the ultraviolet light? There will be the less destruction, and my skin will start to have a repigmentation. Okay. So generally we give two types of the ultraviolet therapy. So UVA therapy. To give this therapy, we need photo sensitizer use. So generally what we seen is, if we give Suralin and then we give ultraviolet A therapy, it is a more effective. We can give it in a localized area every day for 1 to 2 hours. And we can give it as a tablet also. After this, we will send the patient for have a ultraviolet exposure. And then we can give ultraviolet A light exposure. UV A light exposure. And that is why this treatment is known as a TUVA therapy, in which P stands for the Suralin, which is a photosensitizer. Suralin, which is a photosensitizer. We can also use UVB light therapy. Ultraviolet B light therapy. In this, we do not require Suralin. There's no need of the Suralin. It is also known as a narrow band ultraviolet therapy. It is a narrow band ultraviolet therapy. We already wrote it is a 292 320 nanometer. So because this patient has a more than 20% body surface area involved, so less than 20% body surface area, you don't have to give anything oral. But if more than 20% body surface area is involved, you have to give oral steroids along with the phototherapy. You can give oral systemic steroids, drugs, oral systemic steroids. And second, which is steroid sparing agent, which can be useful, is azathioprine. So if steroids are contraindicated, so in some patient who has a uncontrolled diabetes and steroids are contraindicated, in that patient we can opt for azathioprine also. किसमें drugs corticosteroid dexamethasone, the most potent steroid. But what we will do, we will not keep the patient for a long period of time. Once the disease is controlled, we slowly will taper. Azathioprine is also can be used as a steroid sparing agent because steroid has a long term very much side effects. So once the disease is controlled, we can take this patient on the azathioprine and we will increase the ultraviolet therapy. So in vitiligo, you all know Michael Jackson had a vitiligo, right? So in vitiligo, I will show you the two important example of the contact leukoderma. See this, these are the contact leukoderma. The commonest agent in India which cause the contact leukoderma in female, it is a bindi. So in bindi, they have a paratertiary butyl phenol as a content. What is happening when lady applies this bindi on her forehead, this chemical goes to the basement membrane and it destroys the melanocyte, but on that area, and because of that permanently there is a destruction of the melanocyte and permanently she will have a depigmented area on her forehead. Okay. No, not every. Only some people will get allergy. Not all people. But nowadays we try that. We don't have this in our bindi. It was on the older days, which was common. Nowadays not. So contact leukoderma. Two example. Contact leukoderma. Commonest agent is a bindi. This is a paratertiary butyl phenol. Paratertiary. वो बता रहा हूँ. एक तो ये हो गया बिंदी. सेकंड होता है फुटवेयर में. In this footwear, there is a, because in the making of this rubber, there is a monobenzyl ether of hydroquinone. And in dermatology, it is the most potent agent. It is the most potent agent to cause depigmentation. It is the most potent agent to cause depigmentation. So this is the example because of the constant contact with this potent agent monobenzyl ether of hydroquinone, person has a depigmentation on that area. तो ऐसा कहा जाता है कि माइकल जैक्सन को विटिलिगो कंट्रोल नहीं था ना, तो अमेरिकन डॉक्टर्स ने क्या किया, मोनोबेंजल ईथर ऑफ हाइड्रोक्विनोन को सारे स्किन पे लगा दिया, तो उससे क्या होगा, वो व्हाइट होगा, है ना। सो इसलिए लेटर ऑन उसको रिस्क रहता स्किन कैंसर का, बट उसकी डेथ तो कुछ अलग रीजन से। But monobenzyl ether of hydroquinone, what you should remember, is the most potent agent to cause depigmentation. Okay. चलो इसका आंसर दो, फिर ब्रेक लेते हैं. After 45 minutes, you will also get a taste, and we will discuss some important pediatric topic also. Okay. Hyperpigmentation is not seen in the hypothyroid. So you will see hyperpigmentation in Addison's disease. Addisonian crisis is the acute thing, but Addison's disease is different. एडिसोनियल क्राइसिस मतलब जिसमें एड्रेनल ग्लैंड अचानक से काम करना बंद हो गया, मतलब आप पेशेंट को स्टेरॉइड दे रहे थे. एडिसोनियल क्राइसिस कब होता है? नॉर्मली हम स्टेरॉइड देते हैं तो धीरे से बंद करना होता है. अगर आपने एकदम से, हाँ, क्योंकि ग्लैंड सप्रेस पड़ी है, सो दिस इज अ हाइपोथायराइड. So in next class we will start discussion with the hyperpigmentation. So we will take a lunch break here, okay? So and meanwhile they will give you that. So you guys will be in the test discussion also, no?